welcome to all of you, esteemed colleagues, students, friends. It's a nice warm day here in the southern hemisphere. I hope everybody is well and in good health. And welcome once more to our series of webinars that has been launched by the AAPS. It's been a great success thus far. We've had some super attendance and some excellent feedback. And so thank you so much for making time to be present. We appreciate your time. I know everybody's quite busy now as it's heading towards year end with all kinds of deadlines. So for our third webinar in our series, it's my pleasure today to welcome Professor Anoop Misra. Now, I think we're quite fortunate and lucky to have such an esteemed speaker today. Dr. Misra has got a very long CV, and I'm not doing him full justice by just condensing it into a few sentences. But just a few highlights to include would be that he is the chairperson of the Center of Excellence for Diabetes, Metabolic Diseases and Endocrinology. That's in New Delhi. And then he's also the director of the National Diabetes, Obesity and Cholesterol Foundation. This is also in India. He has extensive experience in this field, more than 30 years, and that includes teaching, service, and research, of course. And he's published extensively, more than 300 scientific papers, publications, and books. And then he is also serving as an editor-in-chief and associate editor for top journals in his field. And then, of course, with such an illustrious CV goes along several awards that he's been bestowed upon him in India, such as the Padma Shri and the Dr. B.C. Roy Award. So Professor Misra today will speak to us about links between COVID-19 pandemic, the SARS-CoV-2 virus, and diabetes, which is his main field of interest. And so we look forward to an excellent talk. But before I ask him to start, I'd like to just two household items to alert you to. One is that there are certificates of attendance available if you need them. Please just contact Nakhla, who is the secretary of the AAPS, and she will construct that for you and then email it back to you. And then just in terms, when we start now, if you could please mute your microphones, switch off the cameras, and then we allow Professor Misra to speak. He's going to speak for about 30 minutes, and then we'll have some time for questions. Best to raise your hands then. If not, then just put something in the chat, and we will try and give everybody a fair chance. So without further ado, it's my pleasure to hand over to Professor Misra. Over to you, Prof.
Thank you, Professor. Thank you, Dr. Kennedy. I'm indeed privileged to be here in front of you and speaking in front of a very august gathering. My topic is currently very close to my heart because we in India are seeing huge number of patients with COVID-19 and huge number of patients with diabetes as well. So what I've done is in next 30 to 35 minutes, I have put together a package for you, which is very simple to understand. And also maybe some of you are diabetic or your relatives are diabetic. Maybe you can apply some of the things that I'm telling you to your friends or relatives and other people. So I'll share my slide, just one moment. Okay. Now we have since the beginning of the COVID-19, we have published a lot of papers. And one of the top papers is an international consensus in patients with COVID-19 and diabetes. And this is a multi-country consensus. And you can see one of your colleagues here, uh, Jean-Claude Mabane, and apart from many others. Um, Also, we have combined with international leaders to give a global call as far as diabetes and lifestyle changes are concerned to optimize glycemic and blood pressure control in the patient. And there are a number of publications that we have published in last couple of months. Some of them have been cited more than 200 times. Now, as far as Africa is concerned, just a couple of slides here. Um, I have visited Africa a couple of times, some countries, but still I don't know because of the expanse of the continent. I don't know the dynamics and the epidemiology in many countries, but whatever I know, I'll present it to you so that you understand what is happening in the continent and what is happening as far as diabetes is concerned and epidemiological shift. Now, we have written a major review about diabetes in developing countries, which appeared in 2019 in Journal of Diabetes, where we have researched a lot about diabetes in every developing country, but as a whole, we have stressed on Africa as well. Now, some general points here. Rapid increase in diabetes in India, South Asia, other developing countries poses huge challenge due to existing socio-economic disparity. Now, socio-economic disparities are existing in Africa and they are existing in India and many other South Asian countries. And there is a continuous presence and emergence of communicable diseases. Emergence is that of COVID-19 and others. And challenges in care are posed both for type 2 diabetes and type 1 diabetes, but former type 2 diabetes, which is early onset diabetes, the challenges become formidable because of very high number. Now, if you see here, this is the International Diabetes Federation Atlas for diabetes in 2019, and then the middle figures in each continent or each geographical region is for 2030 and then projected to 2045. And if you leave aside uh, other regions and just concentrate on Africa, you see 19 million in 2019 and then 29 million in 2030 and 47 million in 2045. This is the fastest growing region as far as diabetes is concerned. Uh, of course, there are other regions which are also growing, but uh, this is the top of the line. Now, if you look at the in detail as far as Africa is concerned, and taking the data from IDF Diabetes Atlas, you see how many regions have more around 9%, 8 to 9%, and lesser prevalence of diabetes. Uh, I would say anything above 7% will be medium high prevalence of diabetes. India has around 7.58%, and similarly Pakistan around 8% or so. So if you see here, quite a few countries in Africa have around 8 to 9% of the diabetes. Some countries, no estimates can be made. Now, this is the slide I projected when I went to Nigeria, and in the opening lecture there, I projected this particular slide. If you see the right side, the cartoon here, if you see on the right side, this is what is happening in the most developing countries. The fast food, the the more of fats, more of trans fats, and so on. So you can see diabetes with delight, fast food, and nuts about donuts, heart attack math, cancer on the stick, high blood pressure, low prices, and so on. This is what is happening in some urban areas in Africa, and other urban areas are catching up. So if you look at the data, increase in diabetes from 4 million to 25 million, we have already told you about the data. And prevalence rate is similar to or even higher than some developed countries. But more importantly, if you see, the undiagnosed diabetes is very high, 62%. And there is a clear convergence of multiple diseases here, diabetes, tuberculosis, HIV, and this is the pre-COVID-19. Thus, life expectancy just about 50 years, which is low in the region, is further reduced by double jeopardy of communicable tuberculosis, HIV, AIDS, and malaria, and non-communicable diseases just such as diabetes and comorbidities. So the thing is that here are multiple diseases and some are feeding into each other. Tuberculosis, HIV, and diabetes are problematic, and now COVID-19. So now my patients here, they often come in this state. Look at the left side cartoon, and our our nurse says you're at serious risk for dying from diabetes, heart attack, stroke, or cancer. So our patients say, thank goodness, I thought you were going to say COVID. And they won't care about diabetes or heart or stroke or cancer at the moment. This is Africa on the right side on the top, Africa CDC dashboard. This is last updated on 10/7/2020. The cases here, the deaths here, and the recovery. And you can see on the right side, the most cases are concentrated on the southern Africa. Now, WHO estimates are written here. 83,000 to 190,000 deaths and 29 to 44 million affected during first year pandemic. That is in 7th May 2020. And Middle East respiratory syndrome and COVID-19 are converging epidemics. And there are multiple problems in tackling COVID-19: shortage of health resources, paucity of trained medical staff, and economic problems. Now, some of these are existing in all the countries, all of this region and developing countries, and in India, in the smaller cities and in rural areas, similar uh, problems are are existing, and which may cause problem in tackling epidemic of COVID-19. Now, just to let you, uh, sorry, just to let you, uh, uh, handhold you through the COVID SARS-CoV virulence. This may be known to all of you, or maybe some part is not known. So let me just walk it through because this has relevance to what I'm going to talk about as far as diabetes is concerned. If you look at
Hả?
the, I think, please mute your mics, please. Okay. So step one, the virus enters the body. Now look at this. This is the SARS-CoV virus, and these are the spike protein on the top of it. And through several proteins, uh, TMP, RSS2, and ACE2. ACE2 is important, and the virus enters the body. This is the receptor binding of a spike protein to ACE2. And once it occurs, virus enters the body and produces direct toxic effects on the cell. Now, if you look at that, this is ACE2, direct toxic effect on the cells, and disrupts multiple metabolic pathways. Now, among the pathways, the one of the most important is angiotensin converting enzyme pathway, angiotensin pathway. Now, just to recapitulate, SARS-CoV attaches to ACE2 here, enters the cell, there is a viral entry, then replication, and ACE2 here, through which it enters, there is a down regulation. Now, if you come to this pathway, whenever infection or sepsis occurs, angiotensin 1 and angiotensin 2 are this pathway is active. And here there is ACE1. Now, once the ACE2 is present in normal quantities. This pathway is often converted to angiotensin 1,9 and angiotensin 1,7 pathway, which are actually good. These compounds are good. They cause vasodilatation and protect the lung against injury. However, if angiotensin 2 is in excess, then acute lung injury, adverse myocardial remodeling, vasoconstriction, or vascular permeability, they are accelerating. And this will happen once virus enters through ACE2. ACE2 is down-regulated, and this pathway conversion from angiotensin 1 to 1,9 is slowed down, and this pathway angiotensin 1 to 2 is accelerated, thus causing. Now, vascular inflammation and procoagulant state is one of the most important genetic aspects of COVID-2. So it attaches to endothelial cells, damages apoptosis, decrease in the fibrinolysis and increase thrombin formation. If you look at this causes cirrhosis and markedly increase in the inflammatory pathways like interleukin 6 and then procoagulant G-dimer, which causes pulmonary clots. You can see here pulmonary clots. So clotting in blood vessels and lungs and severely low oxygen and heart pressures go high. And step 5 is this dysregulated system. T cells go down, inhibition of interferon signaling by SARS-CoV-2, and hyperactive innate immunity causing cytokine release syndrome. And if you look at this, surge of cytokine storm, damaging all vital organs. You know, this is the look at this interleukin 6, interleukin 10, etc. And this is SARS-CoV, and it may damage multiple organs, thus causing death. So, in short, this is why I presented this, because I'll be referring to this once we are talking about diabetes and SARS-CoV-2. Now, coronavirus is a bad omen for patients of diabetes. There is no doubt about it, and there are now more than 200 papers which actually substantiate this. If you look at this, these are our early publications in April 2020 when things were about being clarified. What is happening? What is happening to the patients of diabetes? Now, look at this. The tall bars are patients of diabetes who are seriously sick among all seriously patients with COVID-19. So, if you look at all patients who are seriously sick, 17 to 30% of the patients are diabetic patients. And if you look at the mildly serious patients, they're not very sick and they're just admitted and with mild symptoms. Not many patients with diabetes. These are smaller bars here. So this was becoming apparent in April that diabetes, once it occurs, leads to severe course of COVID-19. And also it was becoming clearer that it is the top causes of death in patients with COVID-19. Which which kill once cardiovascular disease is on the top, high blood pressure, chronic respiratory disease, cancer. These are, but top is cardiovascular disease, diabetes, and hypertension. And if you look at this on the right side, one of the prime causes of mortality is when the person is above 60 years of age. If you look at that, above 60 years of age, three times more mortality than 50 to 59 years of age, and then another three times. So age is singular most important, and then comorbidities are other important causes of mortality. Now, look at this. This is some of the recent data which we collated and published from 7 countries. And if you look at the diabetes, hypertension, and cardiovascular disease in various studies, uh, from 5% to 39%. Now, there is hardly any data from Africa, but this is the data from India. High percentage of people with diabetes in patients with COVID-19, and similarly, cardiovascular disease and also hypertension. Now, we did a couple of studies during this time to see what is happening to the population when they are under lockdown and what is the projection of patient with diabetes. How will they fare after after the lockdown? What will be their state? What will be their diabetes? This is our first study done 3 months back after 71 days of lockdown in India, an online survey, and we looked at the lifestyle of patients during the lockdown. And we found that some of the habits were not so good. They, they are increasing carbohydrate intake, increasing snack intake, but also some of the patients, they increased fruit intake. And there was no ordering food from outside because all the food outlets were closed. And physical exercise went down remarkably. Weight gain occurred in around 20% of the patients. These are patients with diabetes. And there was widespread mental stress. This has been echoed by almost all publications from across the world. Similar state during lockdown and during the epidemic. We did a simulation model using multivariate regression analysis to see what will happen to patients with diabetes as far as their diabetes and complications concerned after the lockdown period. And this is based on the baseline data was from previous disaster. And we look at that after 30 days and 45 days of lockdown, the hemoglobin A1C suggesting that diabetes control will definitely worsen. But also, some of them will develop more complications related to microvascular disease like eye problem or kidney problem or even amputation. So diabetes patient will fare worse after the lockdown because of the factors which I just enumerated in the previous slide. So if diabetes is uncontrolled, what will happen? We know grossly till now that diabetes patient will fare worse. Will all diabetes patients fare worse? No. That is the question. That is the question we should ask. And look at this data. This data is a very good study where patients who are well controlled diabetes versus poorly controlled diabetes, their mortality at 28 days was seen. And you can see the hazard ratio for patients who are well controlled was 0.14, meaning thereby they are almost normal as far as mortality is concerned. And the moment they are poorly controlled, almost 76% more mortality. And this means also that all the complications, septic shock, ARDS, disseminated intravascular coagulation, acute kidney injury, acute heart injury, everything was decreased in patients who are well controlled by almost 60 to 70%. And acute respiratory syndrome was decreased by 50%. So, meaning thereby not all patients with diabetes are actually going to go into severe course, but those who are well controlled will be protected. So, a control of diabetes is of paramount importance. Now we learned from this was that many patients are getting obese. And so there are multiple reasons: lockdown, physical distancing, self-isolation, and increased socio-economic hardship. Many patients have lost their livelihood, deteriorating psychosocial health, chronic stress, and altered eating behavior worsen obesity in many people. Of course, there was decreased physical activity. People could not go out because of lockdown. And this led to increased fat deposition in the liver and pancreas and hypertension and insulin resistance. What we did was we looked at non-diabetic people and we saw that 40% of them gained weight, with 16% of them experiencing 2 to 5 kg weight increment over 71 days of lockdown. When we analyzed these data using an algorithm, we found that there was 7% increase in the diabetes risk. So till now, what I have presented is that diabetes patients during lockdown and epidemic will fare worse. If they fare worse, they fare worse if they get COVID-19. Well, controlled patients will do well when they contract COVID-19. No, apparently, non-diabetic people have increased risk for diabetes because of the weight gain. And once they become obese, obesity itself is a risk factor for COVID-19 and especially COVID-19 pneumonia because of impaired respiratory mechanism, increased airway resistance, impaired gas exchange, low lung volume, and low respiratory muscle strength. And with comorbidities, this obese patients often have. This will lead to severe cold. Now, interestingly, there is one study which which only looked at non-diabetic people and looked at their 28 days mortality and first did their blood sugar at the admission, and they found very important, but some of them may not be known. They may not have got blood sugar tested, and some people may have gained weight and recently are at risk for diabetes. Those who are apparently non-diabetic, if their blood sugar is even slightly high at admission, the hazard rate for 28 days mortality was 2.3 and in hospital complications 4 times. So, diabetic at high risk, non-diabetic who are obese and who are at even slightly high blood sugar at the admission have a high mortality. Now, people often ask why diabetes increases mortality risk in COVID-19. There are multiple reasons. One thing is clear. People often say, well, you are diabetic, you will have more chances of contracting COVID-19. That is not true. Diabetes patients do not have increased chances of contracting COVID-19, but once they have COVID-19, they have very severe course, as has already been elaborated. Now, mortality risk may be due to impaired T cell function and general impaired immunity. Procoagulant diabetes already is a procoagulant state. And look at the pulmonary thrombotic microangiopathy in patients with diabetes, high chances of coagulation in the lungs. Chronic inflammation, they already have pro-inflammatory state. And once COVID-19 occurs, the further exaggeration of interleukin 6 and TNF-alpha causing cytokine storm. And we have already talked about compromised lung functions because of obesity, compromised cardiac functions, and pre-existing endothelial dysfunction and microangiopathy. So all these are adverse features which will increase mortality in patients with diabetes. Now, factors which cause hyperglycemia in COVID-19. Now, this is interesting. This study was published in 2010, and where binding of SARS coronavirus to pancreatic ACE receptor was shown. Now, this was not coronavirus 2. And in 2010, it was known that once SARS coronavirus binds to pancreas, it causes acute diabetes. Now, look at this. This is hemotoxin eosin stain showing exocrine pancreas tissue in red here and islet cells in the middle. And here is the stain for ACE receptor. Expression for ACE2 receptor, you see high density of ACE2 receptor in endocrine pancreas in around the islet cells. And if you look at the lungs, where the coronavirus is known to attack, you look at this. The immunostaining for ACE2 receptor in type 1 and type 2 alveolar epithelial cells. So this is occurring, but at the same time, pancreas is also is a target for coronavirus. Now, in 2020, recently, another study was done where the ACE2 receptor was expression was seen in various tissues in the body. There are various tissues. But look at this, there's a square here. And if you look at that, the ACE2 receptor in lungs is this is here, and pancreas is here. So pancreas has more ACE2 receptors then lungs. And in this series, 17% of the patients with COVID-19 had severe pancreatic injury. Now, this is something which we have seen recently also. This is one patient of diabetes uh, who presented with fever and coronavirus was positive, sugars were high, but more importantly, if you look at the CT scan of the abdomen, there is a 30% necrosis of the pancreas. So it is directly attacking pancreas. There is a second case report from India and one of the 10 to 15 cases in the world. So we now know that new onset diabetes is occurring when a person is attacked with COVID-19. So this person may not have diabetes earlier and now suddenly has high sugar. Now these are two cases. Look at this 30-year-old male, no previous history of diabetes, no family history, presented with very, very high sugar and urine ketones. And if you look at this, there is a bilateral pneumonia in this patient and with a high levels of interleukins, ferritin, and CRP levels. So this patient, not known to have previous diabetes, developed diabetes due to COVID-19 with acute high inflammation. A second patient, 60-year-old male, presented with fever, cough, no prior history of diabetes, very high blood sugar, and chest, there was no pneumonia. He developed a stroke. And if you look at this, this is the biochemistry of case 2. So these are two cases which are reported from India recently, but there have been other cases reported from all over the world. Now, what are the factors which can cause new onset diabetes? Here, because of high hyperglycemia, high sugars, the ketoacidosis may occur, destruction of pancreas, pancreatic beta cells, ketoacidosis may occur, or hyperosmolar state, and prolonged ketoacidosis may be seen. Now, there are various factors, increased insulin resistance with sepsis, or beta cell destruction. This may be due to direct damage, as I have shown, ACE2 receptor is present in the pancreas, or high cytokines which can cause beta cell apoptosis, use of corticosteroids and other similar drugs, and marked stress. But low sugar also may occur because of poor oral intake or use of hydroxychloroquine. This is our case series ongoing research on new onset diabetes, where we have found that 15 patients with COVID, either RT-PCR positive or COVID antibody positive, were there in patients with 56 patients with COVID with the new onset diabetes, and 41 did not have uh, any uh, any antibody or PCR positive. Most of them were obese. So it is likely that new onset diabetes due to direct attack of COVID-19 or apoptosis of beta cells due to high cytokine load is occurring, but it is not very frequent, and most frequent is still the usual type of type 2 diabetes due to obesity. So this is the composite of risk. SARS-CoV-2 causes beta cell damage, cytokine storm, and which can exacerbate hyperglycemia at admission, during admission, may cause new onset diabetes. They may be these patients, the diabetic patient may have baseline poor control, as is often seen in India and Africa. Drugs are given like steroids, along with obesity, older age, cardiovascular disease, renal disease, a portend very poor outcome. There may be genetic predisposition to COVID-19 severity in some people. So who are at risk? As I told you, not every diabetic is at risk. Now, high risk are long-standing diabetes, uncontrolled blood sugar, coexisting heart disease, kidney disease, stroke, liver disease or lung disease, obese patient, low fitness, frailty, if moderately short of breath after walking for 10 minutes, confined to wheelchair or bedridden, and chronic smoker or alcoholic. Low risk for COVID-19, these patients have well-controlled sugar or blood pressure, diabetes duration which is less than 10 years, non-obese, no coexisting diseases, walking 3 to 5 kilometers daily without obvious shortness of breath, taking balanced and nutritious diet, non-smoker, tobacco chewer, no other addiction, no previous. So if you are well controlled, if you're fit, if you're walking well, if you're taking good diet, you're not likely to have, if you contract COVID-19, not likely to have a severe course in any case. So what to do? As far as we do multiple measures. Again, because of short of time, I'm not going into details of what we should do as far as management, uh, uh, usual management is concerned. But a couple of points I will emphasize. For example, if you're diabetic, then frequent blood glucose and blood sugar monitoring are required during this time, and ensure compliance to the exercise, diet, and drugs. Good hydration should be maintained. If you have marked hyperglycemia, ketones in the urine, foot infection, pregnancy, abscesses, acute abdominal problem, you must see your physician. Even if there's a problem in single physician, must see your physician and sort this problem out. They may require hospitalization. Now, again, I will not go into this particular slide, but mild infection, most of them can be treated at home. Moderate infections, there are certain drugs like SGLT2 inhibitors and GLP-1 receptor analogs should be stopped, and metformin should be stopped. Now, these are slightly specialized areas. That's why I'm not going to go into details of that. If sugar is not controlled, insulin is the best option. And if severe infection, must be hospitalized. Reasonable blood sugar control is between 110 to 180. Monitoring should be done by the patient. Less frequent insulin, use of basal insulin, and if those where continuous glucose monitoring is available, that is a preferable option because that will decrease contact of healthcare worker with the patient. Now, the important point is important, does treatment of diabetes affect COVID-19? Meaning thereby, if we give a treatment, does it decrease the mortality in patients uh, with COVID-19? Now look at this. These are left side is the treatment: insulin, metformin, PPR gamma agonist, DPP4 inhibitors, GLP-1 agonists, SGLT2 inhibitors, sulfonylurea, and their effect on ACE2 expression in animal studies. Almost every drug except DPP4 inhibitors, sulfonylurea, alter the ACE2 expression, and most of them also have anti-inflammatory effect on the models of lung injury, uh, except SGLT2 inhibitors. But if you look at the clinical efficacy of these drugs, only two, metformin and DPP4 inhibitors. Now, metformin, if you look at this, in this particular study, metformin was given in 105 patients, no metformin 179. Those who received metformin had lower mortality versus those who did not receive metformin. And another study, metformin mortality was decreased preferably in females, and possibly females have high TNF alpha, and metformin decreased TNF alpha in such patients. So metformin in two studies, here shown here, and multiple other which I have not shown, decreases mortality. Similarly, if you look at the sitagliptin, which is often used drug and is available in Africa, decreased mortality by 56% in study versus those who did not receive sitagliptin, although both groups had similar blood sugar levels. So this is another drug which can decrease mortality. And there are multiple mechanisms through sitagliptin and metformin can decrease mortality, and I'm not going to details of those mechanisms. Going forward, another drug which is used, SGLT2 inhibitors. Now there is ongoing study that SGLT2 inhibitors are being tried in SARS-CoV infection, and this particular study is the results will be available in December 2020. And theoretically, these investigators say that decreased lactate production and increased cytosolic pH may decrease viral entry. Another drug which is remarkably decreasing mortality is statins, often given in patients with diabetes to reduce cardiovascular disease. Now, in this particular study, statin versus non-statin patients, look at the statin decreasing mortality by 71%, time to severe COVID-19 and time to recovery, all are benefited by statin. And you say that this is a study which is a basic study where cholesterol 25 hydroxylase, one compound, it took away the cholesterol from lipid bilayer of the cell membrane, and which is seen on the right side that SARS-CoV-2 was markedly decreased the moment this compound was given. It could not cross the cell barrier. So, depleting the membrane cholesterol decreases entry of virus, and same mechanism may be extrapolated to statins. This is very interesting. So, what should we do? This is my final slide. What we must do: 6 types of diabetes. This is our publication. Anybody can access that in Diabetes and Metabolic Syndrome, the clinical research and reviews. 6 types of diabetes are known now. Pre-existing poor control, hyperglycemia at admission, hyperglycemia in pregnant patients, hyperglycemia during hospital stay, and new onset diabetes. Most of them carry very high mortality. Of course, this paper also looks at situation in India, place of care, management solutions, etc., which I'm not going to detail. And these are 2 of our papers led by our team that call for action for all physicians and call for action for all nutritionists and physicians. Strict glycemic control is needed in the times of COVID-19 epidemic in India, and that is for the world also, for Africa also, every diabetic person. This is the time for strict diabetes control and strict blood pressure control. And balanced nutrition. This paper looks at all the state-of-the-art knowledge about balanced nutrition, and specifically from South Asian and Indian points of view, and any of you can access these papers from our journal. So with this, I end my presentation. I thank the organizing committee again, Dr. Kennedy, Dr. Professor. Thank you very much for inviting me here.
Thank you so much, Professor Misra, for a comprehensive, insightful, and a really thought-provoking talk. Covered a vast amount of information, and I'm sure there's going to be many, many questions. If our colleagues and students, please just raise your hand, and then we can refer to Professor Misra. But to kick off, the damage to the pancreas, the pancreatic cells you've mentioned, would those sort of, the damage be transient? Is it acute, and can it restore over time, or have you found anything that it would persist even after
That's very interesting.
The virus has gone?
Very interesting question, and nobody in the world has any answer. But let me tell you a course of 2 patients which I have presented. Those 2 patients who presented with ketoacidosis means marked damage to the pancreas, one 30-year-old, one 60-year-old. I showed the slide. Now we have further data on those patients. So those case reports were 4 weeks old. Now we have around 4 to 6 weeks data here. So these patients were initially had ketoacidosis. They were managed with insulin. Over 4 weeks, their insulin requirement went down, and gradually they are shifted to oral drug. What does it mean? Meaning thereby, whatever damage was there in the pancreas is now recovering. Now, these are only 2 cases where this such data are available. There are studies globally going on the new onset diabetes, and we'll be probably wiser after 1 or 2 months. And we have, I've shown you data from our study where we are looking at similar question, but we don't have adequate answers as yet. I'm sure in around 2 months' time we'll be having final data analysis, and I can give you further answer. By the time, many people may have more publications as well.
Fantastic. Any questions? I don't see any hands or comments, or am I missing that? Professor Kennedy, do you see any questions?
None yet.
Nothing. So I'll just, while we're waiting, I've got another question, Prof. Misra. If we're looking now at treatments, and you mentioned the statins, I was just wondering if there were any studies, not on diabetes, but patients on statins, but for cardiovascular complications, and how they responded. I don't know if it's a bit outside of your field perhaps, but to the SARS-CoV-2 virus.
See, statins, if the patient has diabetes uh, and patient is above 40 years of age, it is universal to give statins, but it is not often given. Um, so, if we go by the book, all patients should receive statin, and this overall in non-COVID patient and otherwise cardiovascular in diabetic patient, it overall reduces the future risk for cardiovascular disease. Now, in the patients who have COVID and have diabetes, we advise not to stop statin, and that will lead to two things. One, it may cause salutary effect as far as viral toxicity is concerned, as I've shown you. On the other hand, it will continue to protect heart. But heart protection is, statins is one thing, but there are other things happening here which can damage heart. One is the virus itself, which can cause myocarditis, like it can cause pancreatitis. The second thing is the pulmonary artery microangiopathy and multiple thrombosis which are occurring. So, in addition to statins, we have to give in most of the patients anticoagulant. Now, it could be heparin or some congeners of heparin. Uh, Many patients are already on aspirin. So that is perhaps more important to decrease the acute cardiovascular mortality or acute cardiovascular related events in COVID-19 patients. Of course, other things are required like oxygen and things like that. But anticoagulants are a must apart from statins till the time patient can take orally. If patient cannot take orally, then obviously we'll have to switch to insulin and statins can be stopped for a couple of days.
Excellent. Any questions? Prof. Kennedy is helping me to see if there's any questions.
Okay, but there's one question. Uh,
Yep.
that's a very
Can
good
you
question.
see it?
Would there be a difference in response to severity of COVID symptoms in patients with type 1 diabetes versus those who have type 2 diabetes? Now, this is very interesting question, and there is some studies from UK, from my friend Partha Kar, which say that patients with type 1 diabetes are also have a higher risk for complications. But look at this way. Most of the patients of type 1 diabetes are young patients. And if they are, say, 9 years of age, 10 years of age, or 15, 20 or something, they are not old, so they don't have a comorbid disease, no cardiovascular disease, no renal disease, and they are well controlled. They will, with, if they get COVID-19, first, their chances of getting COVID-19 is less. And second, age is a major determinant, and these people will be protected. But if you look at somebody else with type 1 diabetes who has 20 years of diabetes, is 30, 35 years of age or 40 years of age, he's already developed some complications of diabetes, his blood sugar is uncontrolled, he's a smoker, then certainly this guy will be at high risk. But large scale studies are not there. So right now we know about type 2 diabetes because they are everywhere. The diabetes is every type 2 diabetic patients are everywhere. We know more about them. Type 1 diabetes are in minority and we know less about them. But this is the gist of things that I can tell you.
We've got a hand raised by Mujahid Nasser Hussain. You could please pose your question.
So there is another question which I have already answered, which you have had asked about temporary or long-term effect of direct damage of COVID-19 to pancreas. I have already told you that two cases they were temporary, but but if we look at this, it depends on how much pancreas is being damaged. Now, I have one patient which we have reported 30% of the pancreas is being damaged. Now, that is not going to cause too much problem. Let me tell you that. But if it's a 50% or more of pancreas is being damaged, then certainly it may cause, pancreatic dysfunction in a major way, endocrine dysfunction, and maybe later on exocrine dysfunction also. So right now we know that it is causing mild to moderate damage. Right now we also know that beside direct damage to the pancreas, stress and the steroids and the cytokine storm is also increasing the sugar and maybe causing ketoacidosis. So there are multiple factors among them. This is the one, and likely this is not going to be permanent, but that's my preliminary assessment. I don't have a clear answer to your question.
We've got a question first from Mujahid and then Professor Yasir, who's typed it. Just in fairness, we've got to give Mujahid will probably orally pose the question.
Yeah, there is
Is
one
he
more.
there?
I assume that COVID-19 related diabetes is acute condition. Why HbA1c is highly elevated in these people? Now, look at this way that one, if the hyperglycemia is extreme for 10-15 days, the hemoglobin A1c will become high. It will take recent hyperglycemia into. Second thing is that some of them may have some hyperglycemia earlier also, so we don't know about that. The third thing is there is we have seen recently is that A1C sometimes is misleading in some of these people for reason unknown. Uh, and some patients we have seen that high A1C with normal sugar, and that what is happening to the glycosylation of hemoglobin in such situation we don't know. So as I said, sometimes this is unfolding of already existing diabetes, or or over which acute situation has occurred, and sometimes the patients are slightly maybe pre-diabetic or something over which now acute situation, acute damage and marked hyperglycemia.
There's another question, Prof. Final
Yeah.
question.
In a case whereby a patient is suffering from chronic pancreas damage, will that increase the death rate of that individual due to COVID-19 epidemic? We don't know about that. We don't know whether this COVID-19 will actually damage every pancreas. So that's not known. If a patient has chronic pancreatitis, he is certainly at risk because one organ is damaged, likely sugar is high, likely there may be some exocrine pancreatic deficiency, likely his vitamin levels, likely he may be malnourished because of the malabsorption. So certainly risk may be high, but it will depend on the numbers of years of chronic pancreatitis, severity of chronic pancreatitis, and so on.
Thank you so much, Prof. I'm going to call on Professor Sofala, who is the president of the AAPS, just to conclude today's webinar. And from my side, thanks a lot, Professor Misra, for your excellent talk and the response to all the questions. So over to Prof. Sofala now.
Is there any other question?
I'm not sure if Professor Sofala is there. Then I'll call upon Professor Yasir Wazir just to say a few words to conclude the meeting, please.
Father.
Yes.
Hello, Father.
Sofola is here. Okay.
Can you speak on my behalf, please?
Go ahead, Sofola.
Can you speak on my behalf, please, Father?
Please proceed, Prof. Yeah.
Hello? Hello?
We can hear you, Professor Sofala. Yes, we can hear you.
Can you hear me? Hello?
We can hear you. Please proceed.
Yeah, so Father, so just to crave your indulgence, so you can help me to thank our guest speaker on behalf of AAPS. And thank you for the good talk on COVID and diabetes. We very much appreciate your contribution, and we hope that we'll be able to call upon you later and then talk to you again. So thank you, Father. So can you help me do the vote of thanks, please? Thank you very much, Father. It's up.
It's a pleasure. And thanks to everybody for attending and our guest speaker once more. And we will make available the video online. And remember the certificates you can also request if you need that, the certificate of attendance. And so we'll see you in a month's time. Inshallah. Goodbye. Bye.